Hello, everyone. The Coordinating Center for the National Drug Early Warning System, sponsored by the National Institute on Drug Abuse, is pleased to welcome you to our May NDUS Presents webinar. The NDUS PI is Dr. Eric Wish, and the NIDA project scientist is Moira O'Brien. I believe that both of them are in the audience with us today. My name is Erin Artigiani, and I'm at the NDUS COI. Barbara Kerr and I will be the facilitators for this webinar. We are part of the NDUS Coordinating Center team based at Caesar at the University of Maryland. For those who are interested, you can find detailed information about NDUS, recordings of prior webinars, and invitations to future webinars on our website at www.ndus.org. You will also find instructions for how to join our NDUS network and participate in ongoing discussions with nearly 1,500 experts and concerned citizens from across the United States and many other countries. We have ongoing discussions in a variety of topics, including toxicology, epidemiology, and public health and drug policy. So I hope we'll see you there. We developed the NDUS Presents webinars to work with leading substance abuse experts to explore emerging drugs, timely drug-related topics, and innovative data sources. This month, we are excited to be joined by Dr. Margaret Warner, an injury epidemiologist at the CDC National Center for Health Statistics. Today, Dr. Warner will share some recent drug poisoning death data and discuss enhancements in the timeliness and specificity of drug overdose death certificate data. This webinar will be approximately 60 minutes long, and we encourage you to submit questions during and after the presentation. However, please don't raise your hand. Instead, please post your questions in the Q&A box, and we will get to you in turn. We will hold a Q&A session after the presentation. Dr. Warner, Barbara, and I will do our best to get to all of your questions. And a recording of this webinar and a copy of Dr. Warner's slides will be made available on our website, which again is www.ndus.org. So thanks again for joining us, and we hope you enjoy this webinar. Dr. Warner, I'll turn it over to you.
Today I'm going to be talking about the vital statistics mortality data, as Erin mentioned, and I'm hoping to stave off a lot of questions because the presentation is designed to help answer common questions that people have about these data. The vital statistics mortality data are commonly used to track the drug overdose crisis in the US and have been for quite some time. So we do receive a lot of questions about how the data are collected, how come we present information in ways that we do, and this presentation is designed to address some of those questions, as well as highlight some of the strengths and limitations of the data as a data source, some of the improvements we've made over time, because we always like to highlight the things that we've done, and many of the people on the phone have been involved in some of these efforts. So it's really a collaborative work, particularly with vital statistics, because a lot of the work is done at the state level. The first slide I want to show is something that probably many of the audience is familiar with, and this is the slide showing the drug overdose death rates by opioid category, and highlights sort of recent trends in opioid data. In particular, the slide about the slide highlights the increase in the synthetic opioid category that does not include, covers synthetic opioids, but it doesn't include methadone, because methadone is in a separate category, and you can see that in the light blue color down in the slide. This slide shows death rates per 100,000 population. We age adjust, most of the death rates I'm going to show here today are age adjusted. But from this slide, you know, people are very concerned about this category, synthetic opioids other than methadone, which largely includes fentanyl. And I'm going to show a little bit about that later on as well. But you can see between 2013, 2017, this category was involved in more deaths than the other category in the later years, and the rise was about 71% per year from 2013 to 2017. And again, we're going to talk a lot about where these statistics come from today. I'm from the National Center for Health Statistics, and we aggregate the data from death certificates around the country into this system we call the National Vital Statistics System. And I just show some of the reports we put out from the National Vital Statistics System, but these data are available on Wonder and Whiskers and in a lot of different other formats, and a lot of people use the data, so we do get questions about how we put together the data and how we come to use certain statistics that we use, and so that's what this webinar is designed to cover. So I mentioned that I wanted to cover some of the strengths of the vital statistics mortality data, and one of the strengths is that it does have a very long-term we're able to do very long-term trends. So I show here the drug overdose death rates from 1979 to 2017. And I highlight this because, again, it is a strength of the data that we have such long-term trends. So in the early 80s, you can see that the death rate was around 2.7 per 100,000. But then it started increasing about 1983, if I used a join point analysis for those of you who are interested. In 1983, it starts rising, and from 1983 to 1999, it was about a 5% per year increase. So very early in the 80s, we were able to see, and through the 90s, we were able to see a rise, and it was about 5% per year, which is large relative to other causes of death, a large increase. In 1999 through 2006, we saw about a 10% per year increase. From 2006 to 2014, it was about a 3% per year increase. So a slowing of the increase, which was great news to those of us who were trying to prevent these causes of death. It's still increasing, but not as rapidly. And then from 2014 to 2017, we saw about a 16% per year increase. So that's largely driven by that that category that I showed you before, the synthetic opioids other than methadone. The reason that I highlight this is because we are using this system to track the drug overdose deaths. In the early 80s, we did have indication that this was coming through the 90s, and we were writing reports about it. So I wanted to make that point. And the other point I wanted to make is I've heard a lot of people say that, people that are just starting, oh, the drug overdose problem started in 2014, and I think, or 2013. I think many of us who have been doing this for a long time would really like to highlight this long-term trend in increases. The other value of there's many values of the vital statistics data, but one of the other values is that we can compare it to other causes of death. So these data have been compared to motor vehicle traffic deaths, and I show this slide here with that comparison, and that helps put it into perspective for people that don't have a sense of what 9 per 100,000 deaths is. We also are able to look at life expectancy using the vital statistics mortality data, and we can see a slight impact of the drug overdose deaths on life expectancy, which actually went down, and you can read about that, and you can Google it, or we have some reports. It did decrease, and drug overdose did play a role in that because of the younger ages, well, because the number of deaths increases, but it also impacts younger people, which will impact life expectancy. But using the vital statistics mortality data, we're able to look at that impact. So another strength of the data is we get information on deaths in every death in every part of the country. So in very rural areas as well as urban areas. So this slide shows our estimated county drug overdose death rates from 2003 to 2017. And you can see that the very reddest part is 40 per 100,000. So if you think about that in comparison, to the national average, you'll see that there's quite a few places where it's very high indeed. And you can also see where it was by county where it was in the early part of the crisis. Well, 2003, depending on what your time horizon is, 2003 versus 2017. So I'm going to talk about improvements in timeliness and quality of the data a little bit next. So we are able, in the last several years, we've increased the timeliness of the data in order to make it more actionable. So we have more records received within 10 days of the date of death than ever before. So in 2019, we're up to about 65% of the death records are received within 10 days of the date of death. And that's up from about 7% in 2010. So a great increase in speed with which we receive our information. And that's true, this percentage is for all causes of death, but what we know is that some causes, it takes longer to get the information in. This slide shows that the drug overdose deaths are the slowest to come in at about 16 weeks on average for 50% of the records to be received on drug overdose deaths. We have more data releases now because we are able to get the information in more quickly. Our provisional data is based on a snapshot of the vital statistics data and is that are received and processed by NCHS by a specified cutoff date. So we have quarterly provisional estimates, which are estimated rates. We have focused activities, including the monthly provisional drug overdose deaths, and then we have our final data, which is the data that's received after all the information from vital statistics comes in, and we have analyzed it for quality and completeness. So with our provisional data coming in so quickly, we're able to look at information about drug overdoses over time. So this slide shows the data that the data on provisional drug overdose deaths counts as we know it as of May 5th, 2019. So this is shows a 12-month ending period in October 2018. So we're able to look back 12 months, and we estimate there are about 70,000 predict there's about 70,000 drug overdose deaths during that time period. We know that these data are incomplete because they're not the final, all the data information has not been received from every single state. So our vital statistics mortality data, just to give you a sense, is based on all death certificates filed in the United States and all the states and the territories. And its data include demographic information such as age and sex and race, and geographic information like county. We have information on a disposition, that's information about the decedent, and also on the causes of death. We code those according to the International Classification of Diseases 10th revision. And the states provide the data to CDC, to our National Center for Health Statistics through a cooperative agreement. So as I mentioned before, these data are sometimes called the death certificate data or the vital statistics mortality data, and they're on Wonder and Whiskers. So the information is received from the death certificate. So we have demographic information that is on the death certificate, and also cause of death information. And I'm just going to highlight a little bit about the cause of death section. For drug overdose deaths and for other sudden and unexplained deaths, the information is reported by the medical examiner and coroner. So this next slide shows you that cause of death section blown up, and we have the medical examiner and coroner writes down on the death certificate the causes of death that they believe led to the death, and the causal sequence in part 1, other conditions in part 2, and then how the injury occurred. They describe some more information. There's also a manner of death category for those of you who are interested in whether the deaths are unintentional suicide or homicide, and I can talk a little bit about that during the question and answer if you have some questions. I'm not going to cover that too much during this presentation. So we code the causes of death from that literal text and use that to get multiple cause of death data. And the cause of death coding, I'm going to just briefly touch on. We use the 10th revision of ICD. We've been using it since 1999, which is why a lot of our slides start in 1999, or our data, or when you see data from the vital statistics, you'll see it starting in 1999. All the member states of the WHO use ICD, so that's some good thing for us because we can compare to other countries, but we are subject to using that coding system. It's developed by international work groups, translated into 43 languages, and many countries use these systems to produce their national statistics, just like the US. So with our vital statistics mortality data, we have a lot of different resources for people to use to keep the data as standard as possible, and we work with the states to put these together. I highlight for you the medical examiner and coroner certification handbook that's brown, and on the bottom left-hand side of the screen that gives more information about how they fill out the certificate. We also have some new resources for those of you who have any influence at all over certification and use these data. We have a mobile app for filling out for physicians who want to learn about how to fill out the death certificate. We understand physicians use their mobile phones a lot now for resource. We have a training module that has CMEs, and we also have a very brand new reference guide for completing death certificates for drug toxicity deaths. The ICD-10 codes, I'm not going to go over these in great detail, but these are the ones we use for tabulating, for pulling out really the drug overdose deaths from the other causes within ICD, within all the causes of death that may happen, and we use ICD codes. And there's been some questions about why we use different codes, and I'm happy to go through that at a later date. Some of it has to do with that, that issue with manner of death. We have recommendations, many recommendations for helping to improve these data that are very drug specific. So we worked with the National Association of Medical Examiners to work on the diagnosis, investigation, diagnosis, and certification of the deaths. We're working on an update to that that has more recent information. It's going to be pretty similar to the old recommendations, but it's not going to focus so much on opioids and expand to all drug overdoses, and it also include more information on toxicology. The toxicologists themselves, the forensic toxicologists, are very interested in doing a similar kind of, maybe not a position paper, but a best practices paper around this subject. We work with the Council of State and Territorial Epidemiologists to help improve specificity on death certificates. So I encourage you to look at that, and also with the Association of State and Territorial Health Officers. And these resources are available online for you to review if you have any influence over what's going on in your area, or interested in some of these layouts, some of the strengths and limitations of the data. So our biggest challenge with drugs is the specific drugs on the death certificate. So as I mentioned before, the medical examiner, coroner who's filling out the death certificate should be putting the causes in the cause of death section of the death certificate. And many times, or not many times, about 25% of the time in the past, they'd write something like polydrug toxicity or multi-drug toxicity. So we weren't able to get the specific drugs involved in the death. And that's true in 1999 to about 2012, that about 25% of the death certificates didn't include a specific drug. But we have made major changes and worked very hard to get it up to about 80% specificity now, and we think it'll be higher in 2018. So in 2017, the most recent year of our final annual data, it was about 88% specified. So quite a dramatic increase on the problem that many people didn't think could change. So that's really good news that when we work with our data providers, we can actually improve our data. So this slide shows the percent of drug overdose deaths with the drug specified by state. And you can see that it is not uniformly 88%. Many states are around 100%, and some states are down around 50%. And I should have explained this slide before because it's a little bit confusing. The gray square with the black dot in it is the 2017 number. The green dot is the number of drugs specified in 2000. And it really is meant to highlight the change in states' practices where we've improved greatly in many states, but we still have a ways to go. So the next thing I wanted to talk about was what we were doing with that more specific information. In addition to being able to put together a slide like this with greater accuracy, because we're now at 88% specificity instead of 75%, we're now looking to get in more detail about what are in these categories. So as I mentioned, this category, synthetic opioids other than methadone, many people want to know, how many fentanyl deaths there are, not this category, synthetic opioids other than methadone. And I'll tell you before, back in the 2011 and 2013, many people were wondering how many oxycodone deaths there were in the natural and semi-synthetic opioid category. So what we're doing at the National Center for Health Statistics is we're looking at more detail in what is in that ICD-10 category. And I have a report here where we have outlined some of that. We've gone through and looked at the specific drugs in each of the categories. So the examples of the common drugs and found on death certificates without a specific ICD code include fentanyl, oxycodone, hydrocodone, morphine, hydrocodone, and tramadol, and then methamphetamines, and also some of the benzodiazepines. And so I don't want to confuse anybody here. We do code these into the ICD-10 categories, but they don't have a specific ICD-10 code. For instance, the heroin in this slide and the methadone in this slide have their own ICD-10 category, but oxycodone and hydrocodone and fentanyl do not. So we're able to pull out the specific drugs using a new method, and that method is outlined in the papers that I have referenced. So when we did look at the specific drugs, again, I'm trying to go back and forth here with this presentation, a little bit about the methods and a little bit about the results, because I know some people want one and some people want the other. So the top 10 drugs involved in deaths, we were able to pull out using a new method to look at the specific drugs irregardless of the ICD-10 category. So we compared the drugs in 2011 to the drugs in 2016. And you can see that in 2011, there were 5,000 deaths, 5,587 deaths involving oxycodone, and it was the largest percentage of drug involved. And by 2016, fentanyl was involved in more deaths, and about 18,335. And methamphetamine changed quite a bit during that period too, going from about 8th leading cause drug involved to about the 4th in 2016. So a lot of changes in the types of drugs involved in death over this time period. We were able to look at, we went down all the way to 2015, to the 15 causes, and there was some discussion amongst some of the people on the NDUS group about tramadol, and I wanted to show tramadol down there at about 1,250 deaths in 2016. We are working on the 2017 report. I was hoping that we'd have that done by the time this presentation came to be, but it looks like we'll have the 2017 data around mid-summer. And then the 2018 should come out very close to the time that the final annual data comes out, which is going to be in December or of this year. So one of the questions that often arises is how many drug overdose deaths involve other drugs? In other words, this question of polysubstance being involved in deaths or more than one drug. So I put together, I pulled out some information from our report, and you can see that in 2016, fentanyl, about 70% of this fentanyl deaths also involved another drug. The benzodiazepines are much less likely, are much more likely to involve another drug. Almost all of them, when there was a benzodiazepine, there was another drug mentioned on the death certificate, and methamphetamine, about 50%. So this slide shows some of the common combinations. So for fentanyl deaths, about a third of them also involve heroin, and about 25% of them involve cocaine. And then, so I don't have time to go over all that detail about which drugs were involved in which death, but I encourage you to look at this slide later on during your spare time, and the report is, a link to the report is on the bottom. So we're looking toward the future to strengthen the mortality data, to try to increase the speed with which we get the data, and also work again on the accuracy. We have some, or the accuracy about which drugs were listed and other quality measures. So our mortality data flow through a very complex system where physicians and medical examiners fill out the cause of death section of the death certificates, and the demographic information comes from funeral directors. They report this information to the state vital registrars, oftentimes through death registration systems, or through death registration systems, which are more and more electronic. They then report the information to the director of the vital statistics system at NCHS, and then we put out reports. Some of the information ends up in the National Death Index for those of you who use that, and we have our surveillance and public health restricted data as well. So there's a lot of data out there, and we're trying to work towards getting that information flowing in a more timely way. We have a lot of work going on getting information to the EDRSs and our vital statistics director, but we know many people use information from the medical examiner case management systems and want more detail from medical examiner and coroners, as well as toxicology. So we're working to try to make the data flow better between these different systems. So our goal is to not only make the data flow better, but also make it easier for our data providers to get us the information that we need, and also to make it easier for them to use the system for their own purposes. So we formed what we're calling implementers groups to work on these data flow issues. And here's our implementers community. We're trying to use a standards-based approach. We are using a data standard, or promoting a data standard called FIRE, which you can learn more about from some of the references I provided below. But the idea is that you put together a data standard, and then you work together with your data providers to create a system that is not somebody making data standards and then trying to implement them. You're doing them in tandem. So I mention all this in case anybody in the audience has some interest in working with us on this. We're always looking for getting partners to help in this area. And I know that many of you work in different agencies or offices where you have impact on these different systems. So far we've developed our HL7 FIRE standard. We have other HL7 messaging data standards as well. And we've put out a implementation guide for balloting. And we're working on starting other data standards, particularly for medical legal death investigation, which should help standardize data within those systems. So I wanted to end with a quote that I often see, or that often see in medical examiner conferences, but I think it fits here, and that's, "Let the conversation cease, let the laughter free, for this is the place where the death delights to help the living." We collect this information and we put all the work into it to help us to figure out how to prevent deaths in the future. So with that, I wanted to thank you very much and open it up for questions.
All right, thank you so much, Dr. Warner. That was a great presentation, and we really appreciate all the data you shared and the information and important things to keep in mind about the death certificates as well. And just to remind everyone, please submit your questions using the Q&A box, and I will read them out for Dr. Warner to answer. And also, if there is anything you want to look at again, or if you maybe missed part of the presentation today, we will put a copy of Dr. Warner's slides and a recording of this webinar on the NDUS website at ndus.org. So I'm going to switch over to questions now, because I notice we've had several coming in. And so the first question we have is, are there states where the percentage of drug overdoses is codified as homicides is larger?
I have not looked at that recently. There are very few death certificates where the death certificate is codified as a homicide, at least through 2017. So it is becoming something that the medical examiner and coroners, some of them are reporting them as homicides because of ongoing investigations and criminal prosecutions, frankly, around the deaths. So it is, I don't believe there are any states, well, there may be one state that's a little higher, but I don't want to say without looking at the data. But we are working with the vital registrars and with the medical examiner and coroners to address this issue. We did address it. As I mentioned, we're working on updating our position paper, or the medical examiners are working on updating their position paper, and they did address this in that issue, in that homicide and suicide, and well, really homicide has a very specific meaning to medical examiner and coroners, and I didn't put it up there, but they have a guide to manner of death classification, and manner of death is a way to describe intent in this. It's slightly different than intent, but it's the check boxes for manner of death, and so you can look at that manner guide for how they determine manner or intent of death. And it is something that we are going to be looking at with the vital registrars to ask questions about the particular designation as homicide, suicide, or unintentional. So thanks for the question.
Okay, thank you. And the next question we received is, if someone overdoses in one state and is buried in another, at what level is the funeral home and medical examiner data reconciled?
Well, let's see. I'm going to break apart that question because the investigation and the certification is for the state in which the person died. So if you live in one state and you die in another state, the information, your death is investigated using the investigation system in the state, and sometimes it's in the county where you died within that state. The reconciliation of the information, the state vital registrars through one of those data systems that I showed with that data flow, one of the things that they do exchange information on is deaths of their residents. So the two states share data about who dies in their state in another state and vice versa. So pretty elaborate system actually to get the information reconciled. The medical examiner information would not necessarily be I don't think in many cases would be reconciled. That's a vital statistics function to keep track of the people who die within the state. The medical examiner or coroner would keep track of the deaths within their jurisdictions.
Okay, thank you. There are a couple participants who send their thanks for the presentations, and our next question is specificity. Will you be conducting and releasing the drug-specific analyses on an annual basis?
I'm trying to recall if we do that already. If we don't, if that's of interest to people, we can do that. I'll bring that up. I think that maybe the National Center for Injury Prevention and Control puts that information on their website, and I can follow up with you, Erin, in the answer to that question, but I'll bring it up to make sure that we do include it.
All right, thank you. I think that would probably be useful to a lot of people. Our next viewer asks if you can comment on the validity, accuracy, or completeness of death data between states with centralized medical examiner systems versus other kinds of systems like coroners.
So it's funny, I did not put information about medical examiner and coroners in this presentation, but it's something that I do know quite a bit about. And I guess I'm going to answer that in a little different way than maybe, I guess, you know, there are different training and different types of offices around the country for medical legal death investigation. That's sort of the medical legal death investigation is the overarching way to describe the work that medical examiner and coroners do. So they they should be investigating the death. They should be determining whether to do an autopsy or an external exam. Then the other thing they do is toxicology testing, which is of course very important to this group. And it really shouldn't matter what the title of the office is of the person doing that that investigation if they're doing it in the same way. So they should be using a forensic pathologist to do the autopsy. And the bottom line is that we don't have a good sense yet whether certain offices or certain qualifications are making a difference in the drug overdose data. We did have early on, I did looked at the specificity information by whether it was a medical examiner or coroner office, and in fact, coroner offices had lower specificity, but I think some of that was because they just didn't know to write the drugs down that they were that they found on the during their investigation. So the short answer to that is no. We don't have good sense about which investigation, whether there's a difference in the investigation system, but we are going to be looking at the data in various ways in the future.
Okay, thank you. We have a few questions coming in from viewers who are interested in knowing a little bit more about the drugs involved in the death and how that's calculated. And the first comes from a colleague who used to be a medical director at a poison center, and she wants to know how the hierarchy of the drugs is determined in a death. And she comments that she has seen OCME reports where drugs are listed alphabetically, others where ethanol or alcohol is always listed last, and others where heroin might be listed ahead of fentanyl.
In our analyses, yeah, I understand the gist of the question. In our analyses of the data that we're provided of that literal text, we do not look at the order that they're listed on the death certificate. So in our analysis of the analysis I just showed of the specific drugs, we don't look at the order. We just say, was it present or absent? Was it listed or not listed on the death certificate? And we do look to see whether the context, to make sure that the context indicates that the drug was involved in the death. So in other words, it doesn't say not heroin death. But we don't look at the order in our analysis. That doesn't, there is some question about which drugs the medical examiner or coroner may put on the death certificate. So in other words, if it's a multi-drug toxicity, some medical examiners will pick the drug with the highest concentration or has the greatest, makes sense with the other information they have from the death scene, either about the symptoms immediately prior to death or the types of drugs that were present at the scene. They may choose a particular drug or not a particular drug to list on the death certificate. And one of the main focuses of the current position paper is about how to decide which drug, if there's multiple in the toxicology. Then there's a follow-on question to that, which is which drugs did they test for in the beginning? So it's a long chain to get to the data that we have on the death certificate from to try to answer that question. So I hope I answered it well enough.
Yes, thank you. The next question is, assuming that percentages are not mutually exclusive, how many overdoses listed both heroin and fentanyl on the death certificate?
So the question was, how many heroin deaths also involve fentanyl? Or was it the other way around? How many fentanyl deaths already also involve fentanyl? So I can answer the question in both ways. So because you get a different answer depending on the question. So the question is how many fentanyl deaths also involved heroin, it's about 32%. And if you ask the question, how many heroin deaths also involve fentanyl, it's 37%. So some of the problem with multiple drugs and how to analyze it and how to report it is about this, you can look at it from one way or the other. So I'll leave this up for the viewer to look at.
Okay, thank you. We do have several more questions here, so I'm gonna skip to one from someone who is interested in knowing how well is the testing for multiple drugs done across states and time. That is, do all states and counties specifically test for fentanyl, and how long have they been doing so? It's kind of a big question. But,
Well, I'm sure some people on the phone could answer this question a little more precisely than I can, but I'll give it my my answer since I'm answering the question. We know that fentanyl. We don't know which battery of tests any. Some states have a better sense than others about the batteries of tests that they're running around the country for different drugs. We know that fentanyl, and now that I'm answering the question, fentanyl, it depends on whether you're talking about the analogs or like the pharmaceutically manufactured fentanyl, because different tests will give you different, to test for the, and I can show you here with my slide how many different fentanyls there are, and this is just a, so if you look at fentanyl, the fentanyl analogs is all those different names, and there's actually many more. And, and this is how we categorize the fentanyl analogs. So I don't imagine that there are many toxicology labs that do tests for many of these drugs, but many do not. So we don't have a great sense for how many there are that do and don't. And maybe somebody on the phone will say, no, we've done a study in the last year and a half that I don't know about, but I don't think that's the case.
okay,
But I wanted to say that was one. So I mentioned that the medical examiners are doing their position paper to talk about making sure the diagnosis and investigation and the different procedures they do during the investigations are more standard, and the forensic toxicologists want to do the same to give some recommendations around the types of tests that they should routinely do. But it's ever changing.
okay. So I have a couple questions here along the same line from viewers who are interested in, if from the data that you have and that you're using for your analyses, if you can distinguish between, for instance, overdoses involving diverted pharmaceutical drug, like diverted pharmaceutical fentanyl versus illicitly manufactured fentanyl, or if you can tell anything about the amounts or concentrations of the drugs involved in the deaths.
I can answer the first one very easily. We don't know anything about the concentrate. Well, we know that the concentration of the drug was enough that the medical certifier felt it was important to list in the causal sequence leading to death. So in that way, we know that it must have been, for that particular individual, their age, weight, size, that amount of drug was enough to be part of the causal chain leading to death. That we do know, but we don't have specific concentrations of drugs. These are post-mortem cases anyway, so concentrations are also related to factors in the post-mortem redistribution of drugs. So the question about the pharmaceutically manufactured versus illicitly manufactured.
Right.
Heroin is illicitly manufactured, so we can for sure say that we know about that. But in terms of the fentanyl, if it's one of the analogs that's illicit, we sure can tell it's illicit. But other than that, we don't have much information. We have tried to mine the literal text to look and see whether it says prescription or non-prescription, and it does in some cases, but it's not consistently reported, so we can't say much about it at all, whether it's prescription or non-prescription. And I would add that the medical examiners themselves often don't know that information either. And there's also the case that it may be prescription medications, not to the decedent as well. So they don't really delve into that as much.
Okay, just have a couple last questions here. Next is, could you expand on what kind of new partners you're looking to recruit, particularly at the local level?
We would like people who have, one of the things we want to know, and actually at the local level, because I tend to work a lot on the national level, and we want to know some of the information that you would like to know. That's, it may seem, you know, some of the things that you know just off the top of your head about what types of drugs, you know, what type of information do you need to know to do your work, and why would you need that information, is the first, is one of the things that we are interested in partnering. And if you have any information on the IT systems within your county, because many of these many of the activities around death investigation, and particularly in coroner, county coroner states, are at a county level. And sometimes those are medical examiner states. So it's not a coroner medical examiner thing, but it's a county-based activity. So if you work at a county and it's particularly a rural county, that would be helpful to just get your partnership. It's, you know, I sit all the way up here at CDC, and there's a whole lot of, you know, I know what my federal partners want, but we know less about what, we know more about what states want, but probably less about what a county-based person wants. So.
Okay, thank you. And I did launch our brief poll. It's just 3 questions. We'd like to get some feedback from those of you who joined us today about what you thought of this webinar and what other topics you would be interested in. So I'd appreciate it if you take a couple moments to answer those questions for us. And meanwhile, we will go on to our last question, which comes from a viewer who would like to know which death certificate fields are used to determine an ICD-10 code in addition to the cause of death field. For example, are the fields for other significant conditions and how injury occurred used when assigning ICD-10 codes? Is this something you can address?
Yep. So, yes, I can. All those fields that you mentioned, the Part 1, the causal sequence leading to death, the Part 2, the other significant conditions, and as well as the how the injury occurred, are involved in determining the ICD codes. The how the injury occurred is, there's a large manual on how to do this, so I'm going to summarize it very briefly. That how the injury occurred is less important than the other 2 boxes, but it is used for additional information, particularly for drugs and injuries. So in other words, if there's more information in the how the injury occurred box, which complements and enhances the information in Part 1 or Part 2, they will use that information. There are other check boxes that are used. That I can't remember the long name of the box, but the box for tobacco use has some implications, as well as the maternal checkbox. And so, but anything, you can look at that part of the death certificate that I showed. But if you have a particular question, whoever this viewer is, I can, you know, I field questions like that quite often about how the codes are done, how the coding is done.
All right, well, thank you very much. And you can see that we have up Dr. Warner's email here. So if anybody has any questions we didn't get to today, or you think of anything else later on, you can get in touch with her that way, or you can also send your questions through to us at ndews@umd.edu, and we will be happy to help you out as well. And in the meantime, we will be posting Dr. Warner's slides and a recording on our website at nnews.org, and I'll make a post to the NNews Network and let you know when that information is available. And I thank you all who are left with us this afternoon for joining us and for chiming in with your questions and comments and taking the time to complete our little poll. And I hope that you will join us again. Our next webinar will feature two presenters who will be talking about the ODMAP system and how to leverage information from that, which basically collects real-time information on overdoses and the use of Narcan as a part of collective partnerships and linking justice and public health to address the overdose epidemic. That will be on June 18th at 2 p.m. Eastern. And we will make available shortly information for registering for that webinar as well. So thanks again, everyone, for joining us. And we hope to see you again. And we hope to see you on the NNews Network as well.